Fantastic. Great. So shall I kick off with my talk? It seems like we're pretty heavy on peds, aren't we? We've only got like one or two people who work in grown-up world. So that will be, hopefully it'll still be interesting for you. I don't know how much lung ultrasound in COVID you guys do in peds, but in adults, it seems to be very useful. So I'll just share this talk about lung ultrasound for COVID. Hopefully you can all see this. So this will be about half an hour or so, and then I'll hand over to Jonah, and then we'll do a bit of discussion. But feel free to just type questions in the chat, and then hopefully Jonah or someone can just interrupt me because I won't be able to see the chat from this screen. Okay, so why use lung ultrasound for COVID? So I think there's sort of three theoretical reasons why it's perfectly suited to the disease. One, because we know COVID tends to affect the peripheral lung, and lung ultrasound looks at the peripheries. Two, because we know chest X-ray and PCR are poorly sensitive for this disease. So chest X-ray generally around 60–70% sensitivity, even less in more healthy sort of ambulatory patients. And PCR, it depends a bit on when you take the swab and how you take the swab, but also around 70%. And then there's the clear logistical benefits compared to CT. So it can be done at the bedside. You don't have to transfer the patient around the hospital, potentially contaminating other staff in other areas. And there's all the other sort of standard benefits of ultrasound versus CT in terms of, you know, it's cheap, it's quick, you can repeat it, and no radiation. So over the next hour, we'll go through what the lung ultrasound findings are in COVID, quickly review the evidence. Then I've got 3 cases. I'll present our audit data just quickly, and then just talk a bit about how we've implemented our pathway in the ED. Okay, so one of the first papers to come out on this topic was from China, as you'd expect, by Huang. And these are the lung ultrasound findings that he described, and these have also been found in several other subsequent papers as well. So in terms of the B lines, these are the most common finding, and they can sometimes join together and become confluent, which some people describe as like a waterfall. In terms of the pleural line, this is also commonly affected, and so instead of being thin and smooth, it becomes irregular and thickened. In terms of consolidation, this is less common, so in less than half of patients, and when it is present, they tend to be quite small consolidations or subpleural consolidations. And then effusions are pretty rare, like less than 10% of cases. And again, when they are present, they're just small, localized effusions rather than sort of big, symmetrical dependent effusions that you might see in heart failure. Yeah, so in terms of the 4 things, if you're using the trauer approach to lung ultrasound, they are how they are what you see in COVID. But the classic thing in COVID is the distribution of the disease. So it tends to be patchy. So you'll get some disease scattered around with normal bits of lung in between. So you might have a few B lines and a bit of an irregular pleural line in the apex, but then maybe the mid zone is clear with just thin, smooth line and A lines. And then a bit lower down, there might be a little subpleural consolidation. So this patchy distribution is pretty typical of viral pneumonitis and therefore COVID. And this is how some of the CT findings relate to the ultrasound findings. So in Huang's paper, he talks about how the ground glass opacity that you see on CT relates to B lines on ultrasound. The pleural irregularity kind of looks kind of similar on both. So here, there's some disease just affecting a very superficial, just kind of just the edge of the lung there. And you can see on the ultrasound, the pleural line has become sort of fragmented and interrupted. And consolidation on CT looks like, yeah, on ultrasound, it looks like we talked about earlier about hepatization, where the lung kind of takes on the appearance of a solid organ like the liver. So it becomes sort of dark, and sometimes you can see these little pockets of air within it, these little white bits within the darker, more solid consolidation. Okay, so the evidence has obviously been sort of gradually filtering out over the year. So I'll take you on a stroll through how the evidence has kind of elapsed. So first, as you can imagine, from China, there were a couple of small papers, just like 20 patients in each, which found that ultrasound and CT were highly consistent. Then there was obviously the next big spike was in Italy, and the Italians already love lung ultrasound, so they sort of leapt on this, and they came out with a few more, again, fairly small, often sort of fairly low quality studies, like single center studies, descriptive studies, but they also agreed that ultrasound gave a better characterization of disease than just chest x-ray. Then over sort of summer, over a few months, there were again a few more papers kind of just filtering in, mostly from around Europe, but again, fairly low quality, but quite impressive diagnostic accuracy results, though, showing generally sensitivity around sort of 90 to 100%. Specificity was a bit less, but actually just in the last month, in October, we're now starting to see some larger, higher quality prospective studies looking at lung ultrasound in COVID. So there was one by Liefeld from the Netherlands and another one by Pivetta from Italy. And I'll go through each of these in a little bit more detail. So Liefeld was a prospective blinded multi-center trial, about 200 patients, about half of which were positive, as you'd expect, because it was the peak of the pandemic when they did this study. And they were all adults referred for admission with suspected COVID. And they found sensitivity and specificity against a reference standard of PCR of 92%, so sensitivity of 92 and a specificity of 71. So this was slightly more sensitive than CT, interestingly, but less specific. And for their protocol, they required at least 2 zones. So if you divide each lung into 6 zones, so 12 total, they required at least 2 zones to be positive. So you may have had one positive zone, but they wouldn't have labeled that as a positive scan. So that threshold may have also affected their sensitivity. And interestingly, they've found that no patient who had a false negative lung ultrasound, i.e. a negative lung ultrasound but tested positive, none of that group actually required supplemental oxygen or admission. So it seems like the few cases that lung ultrasound misses are the very mild cases, which makes sense. Then Pivetta was published around the same time. This was again prospective blinded. This was a single center from Turin. Again, about 200 patients, about half positive. These were just adults presenting to ED, not necessarily referred to admission. And they used an integrated clinical assessment and lung ultrasound, which I think makes a lot of sense because that's essentially how we use lung ultrasound. We never use it in isolation. And they found slightly more impressive results, so sensitivity of 94 and specificity of 95. They also found that the scan could be done in around 5 minutes. And an interesting point from their paper was that of the 21 patients who were initially PCR negative, but on repeat testing were PCR positive, all 21 of those were identified by their initial lung ultrasound. But when we see patients in ED, they're coming in with just undifferentiated symptoms. So it's not enough just to look for COVID changes. We also have to bear in mind what are the typical findings in the other sort of relevant differential diagnosis. So in heart failure, you also get B lines, but they tend to be more symmetrical and dependent, and often they're associated with symmetrical or dependent pleural effusions. And if you're able to do some echo and incorporate the echo findings into your assessment, that may improve your accuracy at diagnosing heart failure. In terms of PE, generally with PE, the lungs are pretty much normal, so just A lines and normal sliding. You can sometimes see these little hypoechoic wedge infarcts, which look pretty much the same as the little subpleural consolidations that you see in COVID. And again, if you're able to do more extended scanning, you could look at the heart. If it's a massive or a submassive PE, you may see some RV dilation or some septal flattening. And if you're able to look at the leg veins and identify DVT, that's actually the most specific finding for PE. So the presence of a DVT is about 98% specific for a PE, whereas other signs like the RV dilation, the lung ultrasound changes are not as specific. In asthma COPD, generally this lung ultrasound will be normal, maybe a bit of reduced sliding if it's really severe or if you're over a bulla. And in bacterial pneumonia, you tend to get more unilateral consolidation, and it tends to be more lobar, so a larger area rather than just a little subpleural consolidation that you get in a viral pneumonitis. So they're the classic pictures of each of the main differentials. So have a look at this scan and see what you think. So obviously there's a lot of B lines we can see. So what do you guys think? Is this more typical of a COVID pattern or heart failure pattern? So the important, the way to discriminate those two things is whether the B lines are sort of evenly distributed or patchy. And here I would say they're pretty evenly distributed. So in each of those 3 intercostal spaces, we're seeing a lot of B lines. If it was COVID, you might just see some B lines in one of those spaces, and then maybe it would be normal in the next one, and then some changes again in the next one. Also, the pleural line is nice and thin and smooth. It's not thickened or irregular. So we're seeing pretty evenly spread B lines with a nice thin pleural line. So this is typical of heart failure style B lines. And if it was also symmetrical, right and left, that would also be consistent. And if you're able to do echo, and if you saw this image, would someone like to comment on this? Feel free to just unmic yourself and shout out what you think. So this is a parasternal long axis. So for those of you who haven't done a lot of echo, going from top to the bottom, we can see the right ventricle at the top. And this is the left ventricle just below and to the left of screen. And then we can see the aortic valve, and the mitral valve, and the left atrium at the bottom. Would anyone like to shout out what they think was the main finding of this scan?
Poor contractility, septal dyskinesia.
Thanks very much. Yeah, poor contractility, exactly. Yeah, so Joda may talk a bit more about that in his talk, but if you just look at these, the walls of the LV, if you imagine a point in the middle of the LV, the walls should come towards that point by about a third. So, you know, fractional shortening of a third is usually approximately a normal ejection fraction, and they're not coming anywhere near close to that. They're hardly really moving at all, are they? So it's a severely impaired LV systolic function. So if you saw this in combination with the lung ultrasound changes here, that would all be building up a picture with your clinical findings of someone in heart failure. Okay, so how about this one? Would someone else like to comment on the echo first? Just unmute yourself and just shout out. So this is parasternal short axis now. So we've rotated the probe 90 degrees and we're slicing through the short axis of the heart. So this is the RV at the top, and this is the LV below. Would you like to comment on that? Yeah.
Septal flattening, probably
Yeah.
pulmonary hypertension.
Yeah, brilliant. So the septum should sort of retain its nice convexity. So the LV should remain like an O. It shouldn't ever be pushed across by the RV. But here it is being pushed across. And so you can call this the D sign, because the LV, instead of being a nice round donut, becomes like the letter D, because that septal edge of it is being flattened. And does anyone know what this image is on the right? So this is, we're scanning someone's groin here. So I guess you can guess what it is probably. So DVT. On the right of screen.
DVT with pulmonary embolism.
Yeah. So we can see on the right of screen is the femoral artery, and then just next to that is the femoral vein, and all this gray within the vein is clot. So yeah, this kind of demonstrates how like a whole body ultrasound approach can be really useful for the undifferentiated patient, not just looking at the lungs, but also incorporating echo, DVT, and then putting that all together with your clinical findings. Okay, so I think I might have showed this image in the first talk actually. So this is an example of more of a lobar consolidation as opposed to the small subpleural consolidations you can see in viral pneumonitis. So this is a large area of lung that's become consolidated, and it takes on the appearance of liver, so hepatization, and we can see those little bright white air bubbles which are moving up and down within the clogged bronchioles. Dynamic air bronchograms, which is more specific to consolidation. Okay, and how about this? What's this condition? On the CT, we can see some honeycombing, right? And on the equivalent ultrasound scans, on the bottom left, we can see some B lines. And on the top right, we see quite marked pleural thickening, so thickening of the pleural line. So this just demonstrates if you've got a patient who's got underlying lung disease, like interstitial lung disease, then lung ultrasound is basically becomes useless because you can't really discriminate whether there's anything acute going on because they've got all the changes already. They've already got thickened pleura, B lines, so there's no way of telling whether they've got COVID on top of that or whether they've got heart failure on top of that. It just becomes useless. So lung ultrasound is really only useful in patients who have normal lungs to begin with. Otherwise, it's really hard to interpret what's acute and what's chronic. Okay, there's a specific type of B line which has been termed the light beam sign. So this Italian lung ultrasound expert, Giovanni Volpicelli, says that this sign he thinks it's a lot more specific to COVID than just normal B lines. And basically what it is like a big fat B line that just comes in and out of view. So in some unpublished data, he thinks he's only seen this sign in people with COVID. But then in some of the correspondence through the journals, people have described seeing it in other conditions like tuberculosis. So I don't think it's 100% specific, but it may be a bit of a clue that it's more associated with COVID. So when you see a big fat confluent B line, that might make you think, is this COVID?
Sorry, Michael, how is the pleural line in this light beam sign? Because it looks quite thin and regular on the right video.
So on the left-hand image, it's just coming in and out of view. It's quite a broad B line there. And then in the middle image, actually, yeah, in the middle, initially it's kind of two discrete ones, and then they kind of join together a little bit. So when it's joined together into a big, fat, broad B line, that's sometimes referred to as confluent B line or the waterfall sign or the light beam sign. It's all basically the same thing. So you can still get that same appearance in heart failure. When you get loads of B lines, they can just join together. But when you see a big fat B line that's kind of coming in and out of view with normal lung on either side, so like A lines on either side, that appearance is possibly more specific to viral pneumonitis and COVID.
So what I mean is the aspect of the pleural line is not part of the description. The pleural line can be regular, irregular, or would it?
Yeah, I think, yeah, often in COVID, okay, you can get a pleural irregularity or even a little subpleural consolidation, and then you can have the B line coming off the back of that.
Okay.
Yeah. Cool. So we'll go through some cases. So the first case is a 68-year-old female who presented on day 8 with fever and cough. She was pretty healthy, just a bit of blood pressure. She had a temperature, but was saturating well. And that's her X-ray. So have a look at the X-ray and decide what you think of that. So it was reported as normal. And this was her lung ultrasound. So this first image on the left is of her left posterior chest. And then on the right is her right posterior chest. So there's bilateral changes with B lines. On this left image, you can see there's a little bit of pleural irregularity, and then there's a B line coming off the back of the little divot within the pleural line. And on the right-hand image, there's also a little rim of fluid around the lung. So that black strip that's just sitting above and around the lung is just a small localized pleural effusion. So we can see here all the classic changes of COVID, really. B lines, pleural irregularity, a small effusion, and bilateral changes. So this was reported by us as being highly suggestive of COVID, and indeed she tested positive. So this just demonstrates how even with a normal or ambiguous X-ray, sometimes the lung ultrasound changes can be quite obvious. So supporting the idea that it's a more sensitive test than chest X-ray. Okay, so the second case was a young, healthy female healthcare worker who presented on day 7 with slightly less typical symptoms, so some chest pain. She felt a bit hot, but no cough, nothing else. And her obs were fine. Her temperature was normal, saturating well. So in this case, our pre-test probability, I'd say, was sort of moderate. And her lymphocytes were normal as well. That's her chest X-ray. So have a look and see what you think. So I think you'll all agree that's completely normal. And so this is from her left anterior chest. And I mentioned it in the first talk, it can be normal to see 1 or 2 B lines, especially in older people in the bases. But here we're in the upper zone of a young, healthy patient. And this is not really a normal B line either. It's quite a fat one. It's almost like a light beam sign, actually. And so if you see a big B line like this in the upper zones of a young, healthy patient, that's not normal. So we thought she was probably COVID, and indeed she tested positive as well. So those first 2 cases just show chest X-ray can be poorly sensitive, especially in relatively mild disease, and lung ultrasound is a lot more sensitive at picking up disease. So the third case was, again, a young, healthy patient who presented quite early, day 4, with shortness of breath. And his sats were a bit borderline for a young person. So the first image was scanning down the right side of his back, so from head down to toes. So we're scanning down slowly, saving a, this is how I ask everyone to record their images in a long clip, scanning down from head to toe, so we know exactly what we're looking at. And we're coming down towards the base now, and it all looks pretty normal, but now we're sliding up into the more posterolateral region. We see some B lines starting to come in now, and we slide up another rib space, and now there's some more significant changes with B lines and some pleural line irregularity in that posterolateral zone. So that kind of shows how if you just scan down in one plane, you can miss the changes in COVID because of the patchy distribution. So the more of the lung surface you scan, the more sensitive your test will be. And here's another light beam sign. So on the right, it looks pretty normal. And then just now and again, as he's breathing in and out, that broad B line just flashes past. So you could almost blink and you could miss it. Okay, and a couple more examples from the same patient. So this is in his left axilla. So we got him to put his hands on his head so he could get right up high into his axilla. And we saw some more changes there. And finally, the last image on the right just shows a subpleural consolidation. So that dark or anechoic area, sort of round 1 centimeter area that's coming down from the pleural line, that's a subpleural consolidation. And then coming off the back of it, you can see there's a lot of bright vertical artifact or B lines coming from the back of the subpleural consolidation, which is quite typical in COVID. Okay, so yeah, we audited our use of lung ultrasound in April, and we included 55 patients, 23 were positive, and we found sensitivity of 95%. So there was just one patient who we missed, who had presented quite early in disease. We didn't try and calculate specificity because only 5 patients had had CT, so there wasn't really an appropriate reference standard for those. But yeah, the 95% sensitivity, as you saw, is in keeping with international evidence. So next, I'll just talk a bit about how we've introduced the pathway in our department. And if there's any questions on any of the clinical aspects so far, please feel free to shout out.
Sorry, Michael, I've been dipping in and out. About the audit, who undertook the ultrasounds and what training did they have?
Yeah, great. I'm going to come on to that in the next bit. Thanks.
Okay.
Yeah. So in terms of the pathway implementation, I'll talk a little bit about the accreditation process as well. So yeah, in terms of pathway, I'll talk about the role for lung ultrasound accreditation, infection control devices, and the pro forma that we're using. So yeah, in terms of the role of lung ultrasound in the ED, these are some potential roles that it could have. This isn't our current guideline, but these are the main potential roles for lung ultrasound in ED. So I think the most important role is just to improve diagnostic accuracy. And as you saw, we picked up several cases where the chest X-ray was normal or where they'd presented atypically. So number 2 is to identify atypical presentations. So we had quite a few cases in the first wave where people had presented with flank pain or just confusion or delirium, and we weren't really thinking COVID at all. But when we see the typical patterns on lung ultrasound, that can just identify them and make the diagnosis, which is super useful. Number 3, informing whether further imaging is required. So if you have a hypoxic patient with a completely normal lung ultrasound, that would be a prompt to consider PE and getting a CTPA. And then number 4, streaming. So we haven't brought that in yet, but potentially in the future, if we divide the department into respiratory and non-respiratory areas, then there'd be a potential role for lung ultrasound to stream patients to those areas. In terms of accreditation, so we came up with a sign-off procedure specifically for just using lung ultrasound in suspected COVID. So it wasn't like signing off in lung ultrasound generally, and it was based on some theoretical knowledge. So they had to watch like a 1-hour lecture by me on lung ultrasound in COVID, plus do the basic kind of physics modules. And then there was a period of supervision, because we had these handheld devices called Butterfly IQ, which upload to a cloud platform that actually made it really easy to provide some of the supervision remotely. So I could review some of the scans like at home. We had quite a low number of minimum scans. We decided 10 was the absolute minimum, but we encourage people to, the idea is you ask for your triggered assessment when you feel confident that you can identify the changes in COVID, and also you have an idea about the relevant differentials as well, so you can factor in the likelihood with your pre-test probability. But also because we wanted to get people trained up quite quickly in the first wave, we decided to try and make the process as streamlined as possible. I know in other lung ultrasound training programs, like through FAMOUS and ITU, they require, is it, I think 50 scans, is it, Jonah, for ITU?
Not sure whether you could leave there. 30.
30, is it? Okay. Yeah, so because we were going for a very specific, we're only just looking for, is it likely to be COVID or not? We decided 10 was reasonable, also just to get the numbers trained up in time. But yeah, I'm open to criticism about that if you think it's not enough. And then the triggered assessment was pretty standard. Just, do you know how to operate the machine? You know what normal looks like. You know what abnormal looks like. You have an idea about the differentials. You can factor it in with your other findings and some things about infection control and other governance thing, how to label and save the images. So yeah, we managed to get about, we had 20 clinicians signed off pretty quickly within the first few weeks. And so throughout the first wave, we always had quite a healthy cohort of people who were able to perform the scan. Then in August, a lot of people, we trained up quite a lot of the registrars. So in August, a lot of them left. And so now we're training people up again. We're actually focusing on the physician associates this time because they're permanent staff, so they're not going to leave. So we're trying to train all of them up as well as anyone else who's interested. So yeah, infection control is obviously a big issue. So if it's a suspected COVID patient, first only scan when necessary. So we shouldn't just be doing scans for fun. You can do training scans, but it should be, if you are going to do a training scan, you need to save the images and actually get some feedback on it. So we shouldn't just be scanning kind of in a maverick sort of fashion. Then minimize the amount of time and the personnel in the room. So you can save your videos in the room, and then you can come out of the room as quickly as possible, and you can do all the labeling and everything else later. Dedicated devices. So if you only have cart-based machines, then you could have one machine that's dedicated for COVID patients and one for non-COVID. But the ideal thing is to have handheld devices. So we bought 4 of these back in March, and so they're the sort of go-to devices for patients with suspected COVID because they can be really easily decontaminated very thoroughly. You can just wipe the whole thing down. Whereas with a cart-based machine, it's a bit of a faff to wipe down every surface of the machine. You can use probe covers. So yeah, some departments will use one of those big long central line ultrasound probe covers, and you can put the handheld probe plus a phone inside that cover, which is probably the gold standard. We haven't used that. We've just had a very strict policy of wiping down with Clinell's or any virucidal wipe thoroughly after doing the scan. And yeah, use lubricant sachets rather than the bottles. So yeah, the handheld devices, we found them really useful, partly for the infection control and also for the cloud platforms that I mentioned. Yeah, as Ariana said, hopefully we'll soon be uploading to PACS, but in the meantime, the cloud-based platform has been really useful, and we've had sort of weekly Zoom sessions where you can just share the screen, bring up your images on the cloud, and I can give feedback. So it's really transformed the governance, because before then it was just kind of ad hoc system where it would just be up to me to look on the machine to see who's happened to have saved images, and you couldn't really give any proper feedback or have any kind of proper oversight over what was going on. But yeah, I think the PACS VNA system would be even better still. Yeah, there are various handheld devices, Butterfly, Lumify, Vscan, various companies make them. The Butterfly we've got, it's very versatile because it doesn't use crystals, and it's just like an all-in-one probe, so it can do superficial structures and deep structures. It's not brilliant for everything, like for echo, it's not very good, for example, but for lung, it seems to work fine. So we found them quite useful just for doing lung scans. And this is the top half of the pro forma that we've used. So we just came up with this documentation system, because there isn't really a standard way of documenting lung ultrasound findings. But we divide the lung into 12 zones, so 6 zones per side, which seems to be the most common way of doing it. And then we just document in each zone according to this key. So A, if it's normal, then you write A for A lines, I for an irregular pleural line, and then B1 or B2, C1 or C2 for B lines and consolidations, and E1 and E2 for effusion. So it's a gross, just kind of summary of the findings. But I think it gives you a bit of a visual representation of what's going on. And it's a useful process to go through as the operator, so you can actually see the findings, and you can decide, are they patchy, are they typical of COVID, or are they more dependent, like heart failure? And then there's a space for echo and IVC findings, which I think is always useful to do at the same time. And then step 2 is really just a reference table. So for people who are relatively new to this, just to remind them of the typical patterns in the main differentials. So in viral pneumonitis, B lines are very common. Consolidations, you can see, they're less common, and they tend to be small or subpleural. The pleural line can be irregular. Effusions are rare and where present, small or localized. And then the distribution bilateral patchy with interspersed normal lung. And then there's the typical findings in all the differentials. So bacterial pneumonia, heart failure, PE, asthma, COPD, and pneumothorax. And then the final step is integrating your findings with your pre-test probability. So first, you come up with your pre-test probability, which is based on all the information available to you, so including disease prevalence, including the history, the exam, the labs, whatever you have available, lymphocyte count. So you come up with your pre-test probability. Then the middle row is the likelihood just based on your ultrasound. So if there's all the typical findings, then that would be highly likely. Whereas if there's just a few B lines and nothing much else, that might just be equivocal. And then the post-test probability is just integrating those two things in, so it's just a judgment. And then there's just a caution here to beware of the false positives in underlying lung disease. So if the patient has pulmonary fibrosis, then it's basically going to be useless. So you shouldn't put any weight on your ultrasound findings. Cool. So that's all I have to say. I've got some links here to some of those papers and to some other useful articles, which I'm happy to share with anyone. Any questions?
Michael, so on the audit, was that was all done in the first wave, presumably?
Yeah, we just audited the month of April.
Okay. Okay. It would be really interesting to see what it's like in this second wave when we're maybe getting sort of less COVID patients coming through, And certainly the pattern I've noticed in intensive care is we're getting other presentations with acute respiratory distress that we weren't necessarily getting in the first wave. I don't know, you know, people just appeared to be staying at home and self-isolating through their various PEs and STEMIs and all sorts. So it might be very interesting to see in this second wave where the sort of ratio to other presentations, to COVID presentations, particularly in Southeast London, where for the moment, touch wood, our numbers aren't quite as bad as last time. It's very interesting to see if you hit a similar success rate with that. Certainly the literature suggests that you should do, but it might just be interesting with slightly different population mix in A&E at the moment.
Yeah, that's a good point. I mean, I expect the sensitivity will be fairly similar, but the specificity would probably be a lot less. Like, I think our specificity was already fairly low from the first audit. Like, it was difficult to measure because few patients had CT, but yeah, there were quite a lot of reports where we'd said, yeah, likely COVID, and actually it probably wasn't, but we decided not to measure the specificity because of the poor sensitivity of the PCR. But I think, yeah, the data, especially from just over the last month, suggests if you have got COVID and you've got and you're sick enough to be admitted or to need oxygen, then the lung ultrasound will show something. So I think it will still remain to be a sensitive test, but yeah, specificity is more complex and depends on things like if you've got underlying heart and lung disease and the disease prevalence. Cool. Yeah, would you like to move on with your talk, Jonah? I'm very excited to hear it.
Sure. Okay, let me just see whether I can get set up, and then I'll share my screen.
I think you joined just as there was a bit of context to all those animals on the chat, you know.
Yeah,
I
was very confused when I joined back in.
Yeah, I asked everyone what their favorite animal was, just to lighten things up a bit. So there was some context. Interestingly, people tend to choose endangered animals. So there was a lot of polar bears and pangolin. Well, pangolin is quite topical for COVID, isn't it?
Okay.
Is that a good reference?
Well, there we go. I thought it was some pediatric thing, but clearly you were responsible instead. Okay, fantastic. So I've been asked to talk a little bit about lung ultrasound in adult ICU. I unfortunately had to dip in and out of some of the presentations because I'm on call today for outreach. So some of what we're going to talk about in the next 45 minutes or so will be a little bit of a repetition, but maybe that isn't a bad thing to help consolidate some of your learning over the course of the day. So I've been asked to talk a little bit about some of the background of lung ultrasound in adult intensive care, some of the evidence behind it, and a little bit about what we're doing currently and have done over the COVID period. So I've been scanning using predominantly echo, to be honest, but also lung ultrasound since about just before 2015, and like some of the other speakers, I found it really transformative in terms of improving my clinical care. I find with the acutely deteriorating patient or the patient that comes into A&E acutely unwell, doing a rapid lung ultrasound combined with a point of care echo can really help. Let me just turn off all of my pages. Can really help quickly get to the bottom of what the acute problem is with the patient. So let's just imagine a scenario. So you're on critical care in the middle of the night. you've got a 50-year-old man who has come into your unit out of an out-of-hospital arrest. You know that he vomited during the arrest and was intubated at some time after that in A&E. He's now ventilated. He's on fairly high pressures. PEEP's already up there. You're not really getting your tidal volume. Your compliance is down. And despite you being 100% oxygen, you're only getting 86% SATs. You have a listen to his chest, you can hear some crepitations throughout his chest. He's cool and shut down peripherally. You ask for an X-ray, but the radiographer's busy in CT and will be sometime with a trauma patient. So what are the possibilities here? So there's an awful lot going on, isn't there? And it could be any number of possibilities, some of which are all listed on the right-hand side here. And as you've discovered over the last couple of talks, that lung ultrasound can be really useful in differentiating between all of these different causes that are listed here. So it's become my go-to for my acute ABCDE assessment of a acutely deteriorating patient. We've heard a little bit about how it is much better than clinical examination and chest radiography. So some of the numbers here for pleural effusions, you can see both sensitivity and specificity, both noticeably higher in diagnosing pleural effusion. The same comes into case with consolidation and also with alveolar interstitial syndrome. So a really useful modality to use and portable as well. You've already heard a fair amount about Daniel Lichtenstein. So here's the guy who is as a junior intensive care fellow. During his night shifts, he would break into the radiology, into the small hospital in Paris. He'd steal their ultrasound machines, which were great big things back then in the 1980s, and just spend his nights going from patient to patient, scanning patients' lungs, slowly starting to recognise the signs. And then from this, critical care lung ultrasound was developed. I'm not sure whether any of you are aware of the SMAC podcasts. So these are a group of really quite excellent podcasts from the conferences, social media and critical care. And there's a range of both adult and pediatric ICU podcasts there from some really quite brilliant speakers. Anyway, Daniel's got one of them uploaded there. So if you just search SMAC and Daniel Lichtenstein, you can hear a little bit about his account of how he develops lung ultrasound in the middle of the night as a junior doctor. Quite interesting to listen to if you get the chance. So we've been through most of this before, so we'll just rattle through all of these images quite quickly. So this is a normal lung with normal lung sliding here. You can see the ribs on both sides. Let me just see if I can get hold of a pointer. There we go. So ribs on both sides. You've got your shimmering pleura here, clearly sliding. So this is the normal lungs, and then here's lung bases. These are my lung bases. So we've got the liver on the right hand side, and on the left hand side here we've got the spleen, and you can see that lung curtain coming down, and as the air moves over the ultrasound probe, you can see that it just obliterates the image. These are my lungs predominantly because when I came to collect images for a previous talk, I scanned every patient on the unit and couldn't find a single pair of normal lungs, so in the end had to resort to scanning my own. We've got, and then I think it's probably worth just touching a little bit more on B lines. It's already been alluded to in multiple of the previous presentations. The B lines don't just represent pulmonary edema. More accurately, B lines represent interstitial syndrome. So this can represent a whole number of pathologies, of which pulmonary edema is just one of them. So interstitial pneumonia or pneumonitis might be other causes. You can see it in ARDS, and then you can see it in parenchymal disease, such as pulmonary fibrosis. And when you have a look at the distribution of B lines within adult intensive care lung ultrasound, that can start to give you a clue as to what these B lines might start to represent. So if you have very diffuse B lines that are perhaps gravity dependent, then that might be more suggestive of pulmonary edema B line, whereas diffuse B lines throughout the lung might be more in keeping with interstitial pneumonitis or indeed a widespread pneumonia. You get similar patterns in ARDS. Again, with ARDS, you can maybe get a bit of a dependent type pattern, with the B lines being more prominent the nearer round to the back you get. You can get diffuse B lines with fibrosis. Whereas more localized B lines might suggest more localized pathology, such as a pneumonia or an atelectasis. You might get areas of pulmonary contusions in your trauma patients, or in patients with PE, you might see them within the areas of pulmonary infarction if you're scanning to that level of detail. So here are some different types of B lines. So on the left-hand side, image A, we've got some examples of septal lockets. So this is suggested that there's thickening septa in the patients that you're scanning, and most commonly this will be due to pulmonary edema. If you compare that with the image on the right, these are lung rockets that are more consistent of ground glass lung rockets, and they will be when you CT scan these patients, you'll find that these areas have underlying glass type shadowing on the CT. You can see that there's more of a sort of diffuse, sort of shimmering coalesced B line on this image on the right. You can tell the difference between fibrosis and ARDS. It's difficult, and it takes a little bit of time to get your eye in. Perhaps in the acute situation, it doesn't matter so much differentiating between the two. But this is a picture of lung. You'll see here that got a little bit of a thickened pleura. You can see that the B lines coming off of this sort of irregular and fragmented that change over the course of time. And as you scan the patient, you'll find that they've got a rather non-homogeneous distribution. This is patients with ARDS, or two patients with ARDS. And again, as you scan the patients, they'll have a similar sort of non-homogeneous distribution of his B lines. Let me just see if I can get this going again. Okay, it seems to have frozen, but you might have a decrease in the lung sliding in some consolidated area, and you may get these areas of subpleural consolidations in ARDS. And as let's just see if we can get that image working again. But as the image cycled through, in the second image, you could see that there's a small pleural effusion associated with it as well. Z lines and E lines have been touched on briefly. They're not always referred to as Z lines and E lines. Essentially, Z lines are these short lines that just come off of the pleura. They're normal. They're not B lines. They just extend a centimetre or two down from the pleura and don't reach all the way down to the bottom of screens. Whereas E lines will be sort of B-type lines that appear cutaneous area above the pleura, and they might appear if there's maybe metal fragments within the soft tissue, or if there's surgical emphysema, you might see some E lines. Lung sliding has been touched on in quite a lot of detail. Hopefully you can all by now recognise that this is normal lung sliding, and we've seen the different patterns that you get in M mode with lung sliding. This is a live video, and here we can see an absence of lung sliding between the ribs. And as has already been alluded to, it's very important at this point not to immediately assume that this is due to a normal pneumothorax. There's a number of other conditions, particularly any condition in which that area of the lung is not being ventilated, that will mimic these barcode type signs. And a good algorithm to follow is this one. You start off, see whether there's lung sliding. If there's lung sliding, then there's no pneumothorax. If there's no lung sliding, it does not mean that there's a pneumothorax. You then have to go and assess to see whether there are any B lines. If there are B lines coming from the pleura, then the pleura then the lung must be in contact with the pleura. The two pleuras will be touching each other, so therefore there's no pneumothorax. You can then, if you don't see B lines, go on to see whether you see a lung point, and if you see a lung point, you know that there is a pneumothorax. And you've already seen this image from some of the pediatric talks of a lung point, and this really quite nice image here demonstrates the lung point with the ventilated lung on this side and the pneumothorax on this side. And you can just see from this image the point of which you're ultrasounding as the patient breathes in and out. The lung is just moving like this. It's really quite a nice picture. And then this is it on M mode. I think it's quite useful to say this on M mode. It shows very clearly seashore sign transitioning into the barcode sign there. And then the final thing you can do if you don't find a lung point is look for the lung pulse, which is really I find very useful in determining whether or not there's a pneumothorax there. And if you see a lung pulse, also referred to as T lines, just to add more letters into the sort of confusing mixture that you've been given today already. If you see these T lines here, then that's suggestive of a cardiac impulse being transmitted through the lung. So if this is present, then there will not be a pneumothorax. So that's really quite a useful algorithm just to keep in your head as you're scanning patients. So a lung view, you've already seen my normal lungs as your PLAPS view. So there's your posterior lateral view. So here's an example of some consolidation. You can see some sort of hepatization of the lungs there, and this is shred sign here. This irregular sign there of sort of irregular matter as pus-filled lung meets aerated lung. You can see as well this patient has also got a pleural effusion, and this is called the quad sign there, where you can see a quadrant of black there between the pleura and the lung. More consolidation here. You've got your spleen here, and this is your lung, looking very similar to the liver. This dense consolidated lung. Here you can see some air bronchograms. These white things, so these are the ultrasonic equivalent of air bronchograms. They appear white in ultrasound as there's air trapped within them, unlike the black that you see in chest X-rays. A bit of atelectasis on the left here, and again we've got some air bronchograms. These white bits trapped in the atelectasis. Subpleural consolidations doesn't just happen in COVID, so we can see this here and just beneath the pleura, bit of consolidation just right next to the pleura, and we've already seen this is another example of shred sign here, suggestive of consolidation. Going further, we can see abscesses within consolidation. So we can see a really heavily consolidated lung here, and we can see that there's an abscess within the lung together with a pleural effusion up at the top here. Let's see. There we go. We didn't. There was one image that did have the spinal sign as well. So when you have really consolidated lung and no air, you can have a look all the way through an ultrasound and actually see the patient's spine at the bottom. And that's a good sign that there's really no air in the base of your lung there. Because if there's any air, then you should see the spine up until the point of the diaphragm, and beyond the diaphragm, you shouldn't see any spine as it's be obliterated by the air in your lung. And then here's a couple of nice complex pleural effusions. You can see jellyfish sign here of collapse, consolidated, surrounded by septations in there. So this is clearly an exudative effusion, and you can see multiple septations here, and you can see some this is plankton sign here, so you can just see some sort of free flowing muck just around in the pleural fluid, again suggestive that this is more likely to be an exudative effusion rather than a transudate that would appear all black with no bits in it and no septations. We've already seen an example of quad sign, again of pleural effusion, and more effusions down here. Jellyfish sign, and we've seen this on a number of different images, and again you can see the septations on this image. So blue protocol was touched on previously. In my opinion, I quite like the blue protocol. I think it's got a fairly good evidence base, and I quite like that it just gives you a simple and quick route through to the most likely diagnosis. As Michael has alluded to, it definitely has got problems. You can see how you can, particularly with some of the comments earlier, you can see how you can quickly slip down here, and with inexpert eyes, you could label every B profile pulmonary edema, which clearly it isn't right. But I think it will quite quickly and safely get you to a reasonable diagnosis, particularly if you then combine it with echocardiogram. You're likely to come to a sensible diagnosis. So we've discussed how you will work your way through this, and algorithms. If it's predominant B profile, you're most likely to have a patient with pulmonary edema, particularly if it's bilateral B profile, particularly if it's worse at the basis. It's relatively normal lung. The blue protocol then has you scan leg veins looking for evidence of clot. So here we see a DVT here, and if you've got a hypoxic patient in respiratory failure with evidence of DVT, then it's likely that you're dealing with a pulmonary embolism if the lung's looking normal throughout. If there's no DVT, then you can go and have a look at your posterior lateral point, and if there's any sign of pathology there, either an effusion or consolidation, then the most likely diagnosis it is a pneumonia. If that's or normal, then consider whether you've got COPD or asthma. This middle branch here is talking about if there's localized either a B or C profile, in which case you're most likely dealing with a pneumonia. And if you haven't got a sliding point, then you go down this B prime and A prime route, no sliding points together with B lines. It is most likely a pneumonic type process. Whereas if you've got an A profile, plus a lung point, as already discussed, a pneumothorax. If there's no lung point, then you can go on to do some further investigations. I think lung ultrasound ties in very well with point of care echo, and here we see a number of images from a 35-year-old lady who came into us. Very hypoxic, refusing all radiological investigations. She was 34 weeks gestation, but you can see from this she's got an extremely large RV there and there, that although is moving a lot, is not really contracting in. If you have a look at the area here, the area is just not changing in diastole or systole. Meanwhile, the left ventricle is really small and collapsed. We can see it on the short axis view here, small LV, massive RV, with bowing of the septum there. You can see the septum is really pressing into the LV with a fixed dilated IVC. So this is a patient who's clearly had a massive PE. She actually refused thrombolysis. We offered her based on this scan. Went on to have IV heparin. And actually did very well without having to have any form of radiological investigation. So we talked a little bit about the blue protocol. So that's one evidence-based way of approaching lung ultrasound. They've also gone a step further and developed this FALS protocol, which personally I don't like, but I'll talk you through it and see what you guys think. So this is a method of looking at shock patients presenting to A&E and using lung ultrasound predominantly to go through the rule out the causes of shock. So step one, you first of all got to rule out obstetric shock. So you do a very quick subcostal echo. So just have a look at one view, have a look, see whether there's a pericardial effusion, evidence of tamponade, see whether the RV looks large, i.e. whether this is likely to be an acute PE, and then go straight onto your lung ultrasound and see whether there's any evidence of a pneumothorax there. They're rapidly ruling out obstructive shock, if those are all normal. You then go on to rule out cardiogenic shock, so scan the lungs, see whether there's any evidence of a B profile. If there's lots of B lines, they say that likelihood is of cardiogenic shock. Although I can't quite understand why you necessarily need to do this step to rule out cardiogenic shock if you already had a look at the heart up here. If those are all normal, and this is a bit that I really don't like from this, you rule out hypervolemic shock. If you've got a normal A-line profile, and what they advocate is give fluid and keep giving fluid until B lines start to appear. And the rationale for this is when the B lines do start to appear, when you do start to get sort of more than 3 B lines per rib space, then that starts to indicate that the patient is just about to sort of start to tip into pulmonary edema. And those signs appear there a lot earlier than you're ever going to see them on X-ray. And at that point, you can say that the patient's well filled. For me, that doesn't sit well. I don't think that's good medicine, just giving enough fluid until you're on the brink of the early stages of pulmonary edema. And then they say once you've done all of that, then you can start noradrenaline, because it can only be distributed shock after that. Not widely in practice, this for obvious reasons, but another potential use of lung ultrasound. You can see what I think about. Other innovative uses of ultrasound, particularly if you're in a resource poor in So here's a view of the trachea, just here, and you can just see the movement of the endotracheal tube as you successfully intubate the trachea. Here it is in cross section. So you've got your trachea here. And you can just see at the end there the endotracheal tube just popping through. What does it look like if you do an esophageal intubation? So watch your esophagus on the right hand side here. There's your esophageal intubation. There you go. You can use it if you like. So for the second bit of a talk, I've got to talk a little bit about our response to COVID and how we've been using lung ultrasound in COVID. And if you read some of the guidelines that have been put out from the Intensive Care Society, they feel that lung ultrasound can be useful to aid diagnosis when the patient first presents to either A&E or critical care, to monitor disease progress, and to guide treatment. So if we deal with the first bit, first of all, I agree with everything that Michael said. It's fantastic in helping you to get a quick diagnosis. When these patients are coming into A&E, to quickly move them onto the right intensive care unit. So it's really useful to have an early risk stratification, because often you don't get the PCR results back until later. And as we've already heard, you can get false positives and false negatives. And if you get false negatives and put a COVID patient in a non-COVID area, that can be pretty disastrous for the bed management of the hospital, particularly when we're so stretched at the moment. As generally intensive care come into play, maybe sort of an hour or so into the A&E admission, we've got the added benefit of we can have a look at the full blood count result as well. So personally, my practice has been taking a history and having a look at presenting a complaint and seeing whether or not this fits with the COVID pneumonitis. Scanning with lung ultrasound to see whether they're typical appearances of COVID pneumonitis, and then having a quick look at the full blood count that's usually sort of back within the first half an hour or so, and see whether or not there's a lymphopenia there. And if I've got all of those, it's pretty bundle COVID pneumonitis. In those patients without a typical history, they do sometimes pop up. If you've got a patient with lymphopenia and ultrasound appearances, then I'll generally treat them as COVID positive until proven otherwise. We've had a number of presentations, including a subarachnoid hemorrhage who presented with seizure, who turned out to be COVID positive, that we picked up early in this way. As I'll talk about over the next few slides, I'm really not sure about the validity of the next 2 points to monitor disease progress. You can certainly do it. I'm just not sure whether it's useful in a critical care environment, particularly in a sort of COVID pressurized ICU environment. And guide treatment, I find that really controversial, because I'm just not sure there's the evidence out there. So I'm sure a lot of you will have come across COVID. I know that a lot of pediatricians came and helped us in the various ICU units over the first wave. But it's a really interesting condition, and we're still struggling to understand it. But what we often get is patients that are very hypoxic with really quite good compliance. And what we think is going on with most of these patients, particularly in the early stages, is that we're getting a pulmonary vasculopathy that's causing a dysregulation of the pulmonary vasculature. You're getting all sorts of microthrombi and clots that are appearing within the pulmonary vasculature, and all of this together with the vasodilation that you're getting in response to all of the inflammation within the lungs, are leading to large pulmonary shunts and VQ mismatching that have got these patients that have really got quite good and compliant lungs that are really quite severely hypoxic. So certainly in the early stages, this is not behaving like a sort of traditional ARDS picture. And we see people with CT scans that really, don't show too many changes on the CT, but are really coming in really quite hypoxic. And so some of my colleagues who've published a paper on this have put these images together that show the general phases that you get in a COVID pneumonitis that progresses all the way to multi-organ dysfunction. And so you start off with what's called this type L phenotype, which is where they've got really quite good compliance, low elastance. They have a but really quite easy to ventilate, but are really quite hypoxic. And the dangers here is if you don't get the tidal volumes under control, then you just exacerbate this inflammation. There's a lot of units that put a lot of these patients on CPAP and leave them on that. And there's a real worry that the patient does themselves real harm with the high tidal volumes that they generate during this COVID. And there's a worry that they're just causing more and progress to a sort of more traditional sort of ARDS type picture once you enter the type H phenotype, where you'll get CTs that sort of transform from this type L to the type H phenotype. We have more of a traditional ARDS type looking lung with really inflamed lungs that will need higher peak to recruit these patients up. Interesting as well, it's also postulated when the patients are in this phase that the virus may affect the respiratory centres at a pontine level, and at some point cause the patients to take larger tidal volumes than necessarily required, which may also be a response to the hypoxemia. So it's this then that may drive the patients onto this type H phenotype stage of the disease once their lungs have become so damaged and inflamed. So you can track the progress of this, and I'm sure you've seen lots of people on Twitter and Facebook, or clinicians self-isolating at home, scanning themselves with their handheld devices. So we start off with a mild disease here. You might just have a couple of B lines to start off with. As the disease progresses to moderate disease, these B lines coalesce. And you're getting increased density of B lines and until they almost merge together. And then the next stage is to start to get these sort of subpleural consolidations that we can see here, that then progress to all-out lung consolidation as you start to get this sort of a CT picture. So interesting, and you can definitely see a progression on ultrasound. I guess the question really is this of any use to us in critical care? If you think of that, we've got at the peak of the pandemic, we had some units looking after 25 to 30 patients, all severely ill on high FiO2s. Going around the scanning all of these patients, most of them were obese, scanning both the front and the back. It's quite an undertaking. And you can track the course of the patient's disease by having a look at the patient's inflammatory markers, having a look at their markers for HLH. You can have a look at the ventilator compliance. You can see how you're oxygenating the patient. So I started off trying to track and scan these patients, but honestly, it was just too busy and too time-consuming to do it. And I didn't really know what to do with this information that I was getting, to be very honest. And I was never sure that I was getting more information from lung ultrasound than I was otherwise getting by having a look at the rest of the parameters on the ventilator, and experimenting with people on the ventilator and seeing what happens with their physiology with that. But that's my personal opinion on it. I still used it during the COVID. When I used it, I used it on patients who were suddenly acutely deteriorating. And those patients I wanted to quickly establish, have they suddenly developed a pneumothorax, then fantastic. You can go and do that and get a quick picture of what's going on. But the day-to-day scanning to see, are there more B lines today, less B lines today, it wasn't practical and helpful. It's been really interesting to see the response to the COVID pandemic. Speaking with one of my experienced colleagues who's taught me much of what I know from being an intensive care registrar and then working up. I remember being really struck in the early days of the pandemic. I was sitting down with him, we were just looking through some COVID patients, and he just turned around to me and just said, I honestly don't know how to treat this condition, and I've got no idea what is going on and never seen anything like this condition before. And I thought that was a far more honest approach than a lot of people have taken to this disease. There are a lot of experts who have, experts within critical care who have immediately assumed that what's going on with COVID, immediately assume that it's ARDS, immediately assume that modalities such as CPAP will be the answer for these patients. And I found my colleagues' approach far more honest, and actually he spent a couple of weeks studying it and then started to build up an accurate picture, or what I believe was an accurate picture as to what is going on, rather than immediately tweeting about it or writing about it on Facebook and then feeling that they have to stick with that particular opinion as things evolved, and it became that there was a little bit more going on with this disease than originally suspected. And I think the same sort of happens with lung ultrasound. There's a fantastic online community of enthusiasts out there with lung ultrasound, and there's some really great material out there. But just be a little bit careful. Not everything out there is necessarily true on Twitter, and just see whether these people tweeting just back what they're saying up with an underlying evidence base. And unfortunately, a lot of this did seem to appear over the COVID period, and unfortunately, some quite big organisations sort of jumped on bandwagons with lung ultrasound and started bringing out all of these protocols that aren't necessarily evidence-based, and it really irritated me. So here we've got the Intensive Care Society teaming up with FUSIC, Society of Acute Medicine, and they've developed the next 3 slides. This slide perhaps not too terrible, just telling people how to do lung ultrasound, differentiating people that might have a PE, the people that have got no problem with this side of the slide, where it's sort of more likely to be COVID. But based on no evidence at all, they're making suggestions to discharge people home. They haven't considered pneumonias, so they have considered pneumonias on this slide. Haven't considered cardiac failure on this slide. And then they separate it into patients that have no past medical history. There's a separate one that you have to follow for patients who have mild LVF, and then you can see on this algorithm, anyone with mild LVF, that, well, they've either got heart failure or they've got COVID. So there's nothing in between. A bit scary and simplistic, particularly after all of the talks you've heard over the course of the day about a broad range of differential diagnosis lung ultrasound can bring in. And then you've got a different one for COPD here, and again, very simplistic and a bit dangerous. Patients have either got COPD or they've got COVID, no mentions of heart failure, pneumonia, anything in between. It's just a bit surprising that all of this stuff has been brought out with no evidence. And when you read the full written guideline from the Intensive Care Society, they themselves admit that all of these guidelines, there's no literature evidence behind it whatsoever. They just say, we believe this is the best thing because this has been developed by doctors who practice lung ultrasound, who have looked after some patients with COVID-19. College of Radiologists as well. This is a statement that they put out in March saying that CT had no role in patients with suspected COVID-19. All a bit crazy. I don't quite know where that's all come from. But all of our patients coming into intensive care with COVID-19, we're scanning them all with dual phase CTPAs because you want to know about the small PEs there that most of these patients end up having to determine whether or not you're going to fully anticoagulate these patients or not. You want to see at what stage their disease progression has gone to, which ultrasound will be fantastic at doing, but it's not quite as good as seeing the entire lung, and getting to all of those posterior bits that are really quite difficult to get to with lung ultrasound. And then we can CT them in a couple of weeks' time and see whether the disease has progressed through to fibrosis, whether we're winning, whether there's indeed any lung parenchyma left for us to really be ventilating to continue. So we talked a little bit about disease progression. You can see it. I'm not sure that it's practically useful to scan every patient every day to see disease progression. Perhaps in intensive cares that are less resource rich than us, this might be more useful, but we're perhaps very lucky in our unit that we've got skilled staff that will be able to get these patients to CT, and the facilities to get them to CT if we want to see how the disease is progressing. This is a little bit about our protocol of how we are treating patients with COVID in St Thomas's, and there's a real emphasis here on trying to limit the patient's capacity to cause a self-induced lung injury by generating those high tidal volumes. So we'll get in there, we'll intubate deteriorating patients early, and then control their tidal volumes to try and stop them from going through to that H phenotype of COVID pneumonitis. And so this is a little bit about our protocol here. And it just sort of emphasised the point that you can manage these points without necessarily ultrasounding them every day. And certainly I've seen no evidence of the clinical benefit of tracking a disease with ultrasound day to day. Note here as well, we look at patient compliance before we consider titration of PEEP. In the early stages of COVID, when they've got high compliance and low elastance, there's a real danger with increasing the PEEP too high, because if we try and increase the PEEP too high in these patients, there's a danger that with the good units within the lungs that we just over distend the good units, and that we create shunt by meaning that these good units are just hyper expanded, and their capillaries don't perfuse to these units, so blood instead bypasses via the lung units that are consolidated, so then creating shunt pathology. So we need to be really careful with PEEP, particularly in the L phenotype of these patients. So a little bit on that. There's been some. This is all evidence prior to the COVID outbreak. There have been some explorations as to whether we can titrate PEEP while having a look at lung ultrasound and have a look at the basis and see what's the lowest level of PEEP required to aerate the lung basis. And this study, I think this is from 2012 or so, in the American Journal of Respiratory and Critical Care Medicine, demonstrated on a small group of patients that they felt that they could titrate PEEP to lung ultrasound aeration scores. Although they acknowledge themselves that there's a danger here that you can get over distension of the good units of lung, and you can't necessarily measure that on lung ultrasound. So whether or not sort of increasing the PEEP to levels at which you're aerating the base is necessarily a good thing that we should be aiming for remains questionable. And within the adult literature, there's been some more recent studies, such as this one that showed, although the degree of lung aeration was comparable with the degree of recruitment that you could see on the CT scan when you actually looked at the tidal volumes using ultrasound to titrate PEEP wasn't actually helpful in this particular study. I think there's actually been more literature published on this in the pediatric world, particularly in anaesthesia, titrating PEEP to reduce atelectasis. But it's still an area that needs ongoing research within the critical care world. And here's another one of these guidelines released by the Intensive Care Society based on no evidence that they're admitting to or that I've seen to, and it comes up with this way of scanning patients, and then you identify whether they've got predominant pattern 1, which is diffuse B lines, or a pattern 2, which is more consolidation, and based on nothing, they say that the people with more B lines are possible more PEEP responders, whereas everything that we just talked about with physiology perhaps goes against that. And they're saying that pattern 2, particularly if they've got this pattern more posteriorly, then there'll be a prone responder. And I just find it staggering that people can publish this under big names such as the Intensive Care Society, based on absolutely no evidence. So I haven't been using it. I tried it out on 1 or 2 patients, and it seems to bear no real resemblance to outcomes or PEEP responders or prone responders. So this is definitely another area that needs more research. So how have we been treating COVID? Well, I personally have been using lung ultrasound in the initial phase to diagnose the disease, and perhaps more importantly, to exclude other differentials. I found this together with echo has been really important, and I apologise if the last few slides have been a bit down on lung ultrasound, but I think the main reasons for that is that people have just been jumping the gun a little bit in some areas of COVID, but I completely agree with Michael. In this early phase for diagnosis, lung ultrasound is excellent. And if you in ICU with COVID pneumonitis or any other type of condition, if they deteriorate in front of you in intensive care, using ultrasound for rapid diagnosis is excellent, and I can't fault it. It's as we'll come on to it in the next slide, I just don't think the evidence is there yet for the other stages. We at this trust have been prioritising lung protective ventilation, and we will intubate patients to ensure that happens. In the early stages, it's very important not to over distend the patient with too much PEEP. Just make things worse, and we're trying now to get an early dual energy CTPA as soon as we can to see whether or not these patients have PE, and to see how the lungs look. High dose steroids, we use methylprednisolone 1 milligram per kilogram that we may up to BD 1 milligrams per kilogram. And then we're commonly using anakinra. We also use remdesivir, working very closely with the Inflammatory Lung Disease Service to advise us on that. Anticoagulation, very important for these patients. So we're giving any patients without evidence of PE, we're giving them a higher dose of prophylactic anticoagulation than we would with the normal patients, knowing that they're at higher risk of PE. And clearly, any patients with any evidence of PE with extremely raised D-dimers, we'll just go in there and anticoagulate them. And then these patients just need a long time of waiting, a very safe lung protective ventilation. If needed be, we'll prone them, put them nitric, and paralyze them. And then if time progresses and they're not progressing, then we'll repeat a CT to see what's going on. So as I say, early stages, we're in an acute deterioration. Lung ultrasound very, very useful. But in practice, I personally haven't used it at any of the other stages. So that's almost it, but just a very quick case example now, and just to prove how ultrasound is actually really very useful. So this might actually be a fairly similar case to some of the other ones that we've heard. So this is a man that I saw just the other week in A&E, 55-year-old man, and he was admitted with a severe dyspnea, so much so that he couldn't even speak enough to confirm his name or any of the history. Paramedics thought it's possibly an acute onset, but we really couldn't get much more out of the patient. So he was on a 15-litre non-rebreather mask, which that's at 88%. His heart rate was 100, his blood pressure and the non-invasive coming out at 88 over 40. I got called on the phone to prepare an ICU bed for a patient that, in quote, had classic. And I thought I'd come down and have a look, predominantly because I wanted to catch some more ultrasound images for this talk. Actually, I thought, great, I'll go and ultrasound him. When I arrived there, the team it was amazing. The team were all standing outside. None of them with the patient apart from one poor nurse who was stuck in the cubicle with him. They were all getting dressed into PPE and preparing the anaesthetic ready to intubate this guy. So he'd been referred to classic COVID, but the acute onset history didn't really fit, but maybe that wasn't quite right. There are a few other things that didn't fit. This guy couldn't speak, and what's weird about COVID is you often get very, very sick patients desaturating in front of you, but weirdly they can speak to you, and that was a very sort of unique thing to have to get used to. I'm used to intubating fairly unconscious, obtunded people, not people that I have to speak to and explain why I'm intubating them before I do. But this guy was slightly different. He was really dyspneic. He couldn't speak at all. He didn't have any temperatures or fevers. His feeling, examined him briefly, very cold peripherally. His JVP was up, and he had some pedal edema. So it's clear that maybe there's something else going on here. So here we go. Finally, a bit of lung ultrasound. So this was him in the first point of the blue protocol. So this is sort of up near the apices, between the apices and the nipple anyway. So you can see there's a couple of B lines there, but not looking too bad. And then this is him a bit closer to the bases, and here we can see some good going B lines here. Here on this right hand side, we can just see there's perhaps a bit of thickening of the pleura there. Quite a lot of those thick B lines there. So maybe just have a little think to yourself what could be going on here. And then the real clincher came, and this is why I think you need to learn echo in conjunction with lung ultrasound. So then start the probe over his heart. And here, so we've got the left atrium, we've got the left ventricle here, infralateral wall and anteroseptal wall. We've got the right ventricle here. Here's the aortic valve and aorta there, and here's just a cross section of the left ventricle at the mid-papillary level. So you've got your septal wall there, your anterior wall there, your lateral wall there, and your inferior wall there, and you've got your RV here. So you don't have to be much of an expert here to see that the LV is really pumping poorly. And if you put a spot in the middle here, you can see that these walls down here are pumping quite well towards the centre, but all of this walls of the septal and this anterior wall here look rather thin. And you can see that they're barely pumping in towards that dot at all here. So it's starting to look like pulmonary edema. The combination of these B lines here, predominantly at the bases, together with this LV that's really not pumping at all. We were suddenly a lot more cautious with the anaesthetic we put in an art line, and actually found that he was quite profoundly hypertensive rather than hypotensive. Started him on some GTN, offloaded him, gave him a bit of CPAP, and then intubated him shortly afterwards. And this guy had so much pulmonary edema that when we had a look to see his cords, we couldn't see his cords because they're just pink, frothy white. Pour and out of him, so we had to intubate him blindly. And here's another view of his LV. So right ventricle there, LV there, and you can see actually all in the LAD territory, which is all of this bit here, You can see sort of thin scarred myocardium. You can see that the apex is almost aneurysmal there. And so this is a guy who's had an LAD infarct. And when he was finally still enough for us to do an ECG, you can see that actually this guy hasn't got COVID at all. He's got a missed STEMI, and you can see he's already developing some Q waves there. So he probably had a STEMI a couple of days ago. And unfortunately, this is what we're increasingly seeing. We're seeing patients who either they themselves think they might have COVID, or other clinicians think the patient's got COVID, whereas actually they've got underlying diseases. And you can see from these lung images with an inexpert eye, maybe you may think perhaps this is COVID pneumonitis, but actually in this case it turned not to be. So this is his chest X-ray when we eventually got it. So severe pulmonary edema, and actually did very well with 2 days of ventilation. He extubated 2 days afterwards, after a lot of diuresis, and he went on to have a cardiac MRI that confirmed that he'd had a missed LAD STEMI. So back to that question, where is the evidence? So I think there's been a lot of literature published now, and you'll have seen from Michael's audit that lung ultrasound is really very useful to diagnose patients and to aid diagnosis. I think that's where lung ultrasound is really fantastic. I personally haven't seen the evidence, but that's not true. We know that the lung ultrasound images do correlate well to disease progression. At the moment, in our particular ICU, I can't see how that adds any more to the patient care than other parameters such as having a look at the ventilator. But I'm sure there'll be others of you on the line that disagree with me with that. And then there's a bit about guiding treatment. I don't think we've got any evidence at the moment for lung ultrasound necessarily to guide treatment, but hopefully we'll get some good studies come out that will help us with that. I think the PEEP titrations are interesting and probably does play some role, but for the moment we're not quite sure what the findings mean. So for now, I'm just sticking with its main use, which I think is the rapid diagnosis of acutely deteriorating patient. So in summary, then, lung ultrasound I think is an excellent diagnostic tool, but as we can see from all those differences with all the different types of B lines, it does require knowledge and practice, and there's a bit of a danger because the images are so easy to acquire. There's a little bit of a danger of just assuming that it is all easy. You do have to really get yourself familiar with all the different patterns, types of B lines and distributions of B lines, just so you don't just go around diagnosing either everyone with COVID or everyone with pulmonary edema. Remember that it relies on artifacts, so what you're seeing is actually not always there. So a lot of it will rely on your technique and getting the right settings, and it's a tool to the diagnosis. I certainly remember when I started point of care echo in particular, I thought, well, this is going to be fantastic. I'm going to start doing this, and then I'm going to know the answer to everything. If I can see it, then I know exactly what's going on. That isn't always the case. When someone's very, very sick and they're at the extremes, it's quite easy to see what's going on with ultrasound. But use it as just another clue to get you a bit nearer that diagnosis. Don't forget about the history. Don't forget about the examination. And if you're seeing something in ultrasound that doesn't fit with the rest of the patient, just take a step back and think: is this the way that I'm scanning the patient? Is this my settings? Is this me introducing artifact rather than necessarily there being a real pathology with the patient, particularly when you get started? We've already talked about not every B line is pulmonary edema, and don't forget with all of this, just to sort of not get too carried away on the social media and go back to evidence-based medicine every now. again. So I'll maybe leave this slide up. Within adult intensive care, there are a lot of different courses that you can do to learn more. The acoustic course, I think, is really good. There's different modules on that. You can learn how to do vascular scanning to have a look for DVTs. You can learn about abdominal scanning, lung ultrasound scanning, and echo scanning. There's lots of great modules that you can do both online and in person to get signed off for that. Famous is the acute medicine lung ultrasound course. You can read a little bit more about the blues and falls and protocols, so you see what you think of those. There's a link to that there, and there's a number of really great online tutorials about critical care. Echo.com tutorial 9 is all on lung ultrasound, and this one's really good. I'd recommend this one, the POCUS 101 lung ultrasound made easy. The NHS e-learning website's got a module both on echo and lung ultrasound that you can use, and there's a little plug for my own echo website if any of you want to go on and learn a little bit more about echo. Anyway, I will stop talking now, and I think we've probably got a little bit of time for discussion. So I'll bring everyone back in. I don't know, a lot of that was some of my own personal opinions. I don't know whether anyone wants to disagree with that or make any further comments.
Yeah, that was fantastic, Jonah. I totally agree. Thank you.
I'm very glad to see that across specialties, actually, we use it the same way. It's not as a follow-up. There's not much use to scan our patients every day. But really as a diagnostic tool, when, for example, on our side, when we admit a baby for respiratory distress to make the diagnosis, I can see the emergency department for you, Michael, or Ariane, the transport services, the initial diagnosis to rule out, for ruling out some diagnosis as well is so useful. And I totally agree with what we say. And in addition, we need to have a strong clinical knowledge before taking the probe, because if we want to ask the proper question to the ultrasound scan, we need to have a good knowledge of what our patient look like, all the data, and then because our answer will depend on the question we ask. And we do POCUS not to routinely scan, but because we have a precise question to be answered that will impact on clinical management. So I totally agree with your view.
Yeah,
on this.
Definitely. And remember that all of his studies, both, you know, when you come to FICE, so doing a critical care, point of care ultrasound, together with some of the protocols, such as the Blue protocol and Falls protocol, all of those are done in the setting of an acutely deteriorating patient, and they are most valid in non-expert hands if you're looking at 6 patients, because that's when you're most likely to pick up pathology. If you do them in well patients that aren't deterioration and you don't have that question, then the validity of them falls together with the sensitivity and specificity.
The only area when I find it useful to monitor the treatment is maybe when you put chest drain or your drain effusion. When you see the lung point resolving, or when you clamp your drain, seeing the lung point sometimes going down, you say, oh my God, I need to unclamp my drain before the baby gets worse. So this is something I've been using, but it's very personal. I don't think it's something that I can recommend widely, but I find it useful to monitor pneumothorax and effusion. I don't know what your opinion is on that.
Yeah, I sometimes like to scan while you're aspirating. It's quite nice to follow as the lung re-expands, but we're not allowed to aspirate now as per the new trust guidelines. Aspiration is out, or at least for adults. It's either chest drain or observe.
Yeah, and also, I mean, if you have I would definitely agree, Virginie, if you have an effusion, you want to monitor if your chest drain output is reducing, you're going to get out your ultrasound to see if it's accumulating because of a blocked drain or something like that.
I'm just trying to catch up on some of the chat, actually. Michael, ECG, presumably I answered the question there. So he did actually, to be fair to he have an ECG first thing when he came in, but he was moving about so much you just could not interpret. So there's only once we paralysed him that we were able to get a good ECG. Lee, Garen Lee had a question. So how do we balance intensive need to scan benefits patient with other demands? Yeah, that's an interesting one. So Geraint is just asking about how do we balance the need to scan our patients with the benefits that you get from that, together with all the other on our clinical time. I became a consultant 2 years ago now, and I must say the amount of scanning that I've done has fallen dramatically, just because there's so much more things to do, and it is really difficult getting that balance. We're very lucky in adult intensive care in that we have cardiac physiologists who come and spend half a day with us, and we've got 2 echo fellows who can take on a vast majority of that workload for us. So I tend to scan patients that I'm called to who are acutely deteriorating. I'm there at the bedside anyway, and sort of in place of a clinical exam, I tend to ultrasound it instead, and that doesn't take up too much time. But I don't think I can go around scanning everyone electively. I have to delegate that to just the acutely deteriorating patients.
And probably the more you scan, the more you see when you need to scan and when you don't need to scan. I think with experience, you say, well, this one I don't need, this one, yes, it's really crucial. But I think we learn with time as well. It's something you don't teach on a course. I think it's with experience. This is what I find.
Yeah, I think one of your early slides, Jonah, showed the sensitivity of auscultation for pneumonia was 8%. So it also depends on the clinical condition that you're thinking about. For some conditions, obviously, clinical exam is really accurate, but for other conditions, it's just not. And so just having an understanding of where ultrasound fits into your overall assessment is really useful.
Yeah, and it is a developing field. There's so much we need to learn on lung ultrasound. And I loved your approach of combining heart and lung, because the lung is the only organ that receives the full cardiac output. So of course, if you look at the lung, you have to look at the heart. This really makes sense. That's the way to go, I think.
Good. Do we have any other questions?
There's one more comment from Lee, Jonah. Comparing COVID-19 to giving respiratory support to a very preterm infant.
It was just a really interesting analogy, to be honest, Jonah. We know before we start, when our babies are born, that at 24 weeks, with the best will in the world, you're going to be providing respiratory support for them at a minimum of 4 to 5 weeks, if not longer. And it's beholden upon us not to damage their lungs from the moment that we meet them. And your slide on how you have addressed that in COVID, knowing how long they're going to be with you, is very rings very true to what we do, and was really helpful. And that it is and recognizing the disease of atelectasis and hyperinflation in the same lung, and how difficult it then is to use that to guide your management is really important.
Yeah, I mean, we often don't know when we intubate patients. Some people have sort of criticised our management in terms of we intubate a lot of people, and we intubate a lot of people early, and there are some people who we managed to extubate within a couple of days. But some of the more severe cases will be with us for weeks. But what's really interesting is that in any other condition, particularly with the degree of CT changes, you'd be writing off a lot of these patients. But particularly some of the sort of CT appearances are almost really quite fibrotic, that it somehow seems to just turn themselves around and pull themselves through. But one thing we've learned is we just need to ride it out with a lot of these patients. A lot of these patients will go up to 100% oxygen several times over several weeks. We found that if you just persist with them and keep the sort of safe lung protective ventilation, give them immunosuppression, some of those people do recover.
We obviously have the added advantage that we can grow our patients and try and get them through it in that way.
We try and shrink our patients.
So if we can get them to grow, we have another way out, as long as we can do as much as necessary and as little as possible with their respiratory support at the same time. So
Good. Does anybody has any comment or question before I close and wrap up the day?
We got 35 left on the chat. That's
That's
very
good. Well, thank you, everyone. I would like to thank all the speakers, Ariane on her maternity leave, Michael from Amsterdam, Jonah attending Adult ICU, Anita and Georgina who presented very interesting cases. So thank you, everyone. What I get from that is that the semiology is so similar across specialties. I mean, from the neonates to Jonah, we just showed quite the same images. So that was extremely interesting. And the strong clinical ground and basis, I think we cannot highlight that more. And probably lung ultrasound is more to rule in and rule out diagnosis. And we need to have the right question to ask to use it properly. Interaction with lung and heart, I think, is really a way to go. And thank you for providing this update on COVID, because we just don't have the time to read and to be aware of all the things. To have this 1 hour summary of all what we should know is extremely useful, actually, for us and for me. I think we need to recognize there's no expert, and we get expert recommendations from everywhere, but we're just experienced and very keen people to learn, and it's a developing field. So please learn, and the reason for this group is to learn from each other, from experience, from our specialties, and especially now there are so much similarities. I'm sure this collaboration will be useful. So I have a feedback form, please, if everyone can fill it. I will just show you the QR code. And once you fill this feedback form, you will automatically receive a certificate. So I do that now, but I would leave like Michael, Ariane, and Jonah, maybe if you have another word to say to wrap up.
No, also would like to thank everyone, and especially you, Virginie, for organizing this day. And also the beginning of the day with the the biomedical engineering and physics was very useful and interesting, I think, for us medics, which we normally don't get to get an insight on that as much. So that was very helpful.
Thanks a lot. So can you see my desktop now with the QR code?
Yep.
Yeah, so if you can scan that, fill in the survey. If you can't, I will email the link to everyone. It was just a short way to do it. And Ariane kindly did the certificate that is directly linked to your feedback form, so you should receive it quite quickly. Thank you, everyone. And we will have the next session
as well. Thank you, everyone.
Yeah. The last question on the feedback will be about the next session. If you have ideas, we are planning now to go for crashing algorithm, acutely deteriorating patients, probably sharing some clinical cases across specialties. But if you have any other ideas, something you would like us to teach, to approach, please let us know.
And Virginie, Jonah is just asking about sharing the recordings. Virginie, you're off. You're off.
They are all being recorded. Unfortunately, I've maybe missed the 5 minutes for most of them because I forgot. But all of them have been recorded. And